G'day everyone, this is Health Highlights. Health Highlights is a show about health professionals and the people and the stories behind the names that you hear about but you seldom get to meet. Now, if you've ever been in an operation, you've had someone say to you, count back from 10, and before you get to 9, you're out of it. But what we wanted to do today is actually go a little bit further and go behind the scenes of that and actually talk to an anaesthetist. Dr. Andrew Phillips, how are you?
I'm well, thank you.
Thank you for joining us.
Pleasure.
And he is going to share with us a little bit about what goes on and what an anaesthetist does and the process of their job. So what are we going to see today, Andrew?
Well, Simon, I thought we'd start off, this is the anaesthetic bag. We'll start here, this is all the preoperative preparation, and we'll just run through what we do here, and we'll go into the operating theatre, have a look at the anaesthetic machine, the equipment that we use to put you to sleep, keep you asleep, monitor you while you're asleep and keep you safe. And then we'll see what we can see.
Sounds great, sounds great. So firstly, anaesthetist, how did you get into this profession? Because it's not one of those ones that, like a surgeon that's, big name. So why anaesthetist?
Look, I think for me it was trial and error. I started off doing emergency training in the emergency department, and then I found I quite liked intensive care, so I shifted to intensive care, and I thought that anaesthetics was a complementary specialty, so I did dual intensive care and anaesthetic training, and eventually gave away intensive care and just kept on going with anaesthetics. And I've been, I think I started my anaesthetic training around 18 years ago, so 19 years ago. Yeah.
Wonderful. Okay, so we're here in pre-op or in an anaesthetics bay.
Yep.
So can you just sort of share with us a little bit of what we've got going on here and some of the equipment you have?
Sure. So when a patient arrives in the theatre, they get brought to the anaesthetic bay, and this is our patient today, Lucy.
Doing a great job, Lucy.
Well, so we'll check Lucy in, and we'll identify her as being the correct patient. We'll identify the correct site for the surgery, make sure we're doing the right operation. Lucy's having a tickling of her left foot today, and then we put in an IV line. We just check over things like medications and allergies, and make sure the patient hasn't got any last minute questions. And then we just get set up, ready to go into theatre. So we might put an intravenous cannula in, put a drip into a vein there, and we can run some intravenous fluids through that. We'll go in there. And for major operations, if we want to watch blood pressure, monitor blood pressure beat to beat, then we might put another little drip into the radial artery. So we might just put that in here, and that monitors the blood pressure continuously and allows us to take blood samples off as well during the operation. So if it's a long operation, say 4, 5, 6 hours, then that sort of gives us a beat-to-beat monitor, so we can address changes in blood pressure quickly and effectively, instead of waiting for the blood pressure cuff to do it every 5 minutes.
Wow. So
once we've got IV fluids up and running, we might put a monitor on right here, so we can snip that on. So this just monitors oxygen concentration, oxygen saturations in the blood, so we'll put it on. And that'll give us a number here, so you might find yourself attached to one of these when you arrive in the anaesthetic bay. And that just keeps an eye on your pulse and your saturations. So there's Lucy there, she's got sats of, take a deep breath. So 94, 96 and coming up, I think she's finger's a bit cold. And pulse is 90 there, so that's all fine. And another thing we might do with the anaesthetic bay is to put in a block, use an ultrasound machine to put in a block for post-operative pain relief. So to keep the patients comfortable after their operation's finished for anything up to 12, 24 hours, we might put a small needle in the right spot and inject some local anaesthetic, and that'll hang around for up to a day, so and just keep the patient in less pain, and it means they don't need as much morphine or other drugs to help with their analgesia. So I can show you briefly what the ultrasound machine head looks like. I'm just going to pop it on your leg here. We can see. So you can see here, you can zoom in on that. That's our tissue here, which we're on Lucy's leg. And we've got 2 blood vessels there, which are pumping red and blue. So that means Lucy's either a Jets fan or a Barcelona FC fan. She's got red and blue flowing through her veins, which is fine by Dad. And that allows us to know that there's a nerve here as well. The nerves and the blood vessels travel together, so I can get rid of that now that I know where I am. And we can image the nerve and put some local anaesthetic around the nerve. And we do that safely, and we can inject the local anaesthetic into direct vision.
Yeah, wow.
So we know that we're not accidentally injecting into a blood vessel.
Yep.
And that's at a level of safety. We can see the local anaesthetic where it's going into the right spot, and know that we've got the right nerve and the right block on board. And it's all very safe.
Okay. So that's great. And so when it comes to actually, putting someone under, what is the sort of how does the process work there, and what sort of drugs do you use? Okay, you're dying? No, you're not. It's all right.
Well, once we've got everything hooked up here, and we might give Lucy a little bit of a pre-med, just a little bit of medicine just to relax her and make her feel a little bit sleepy, but not too sleepy, but just relaxed. And especially with children, they may be a bit anxious, so the parent will come in. So the parent will come in here with the child, and the parent will accompany us into the theatre as well, and they'll stay with the child normally until the child's asleep. Otherwise, the patient is a grown-up, they'll go in with a bit of sedation on board sometimes and through to theatres for the operation. We've got some monitors, so do you want to go through and have a look?
Let's go through and have a look. Wonderful. So Lucy's feeling a bit more relaxed now. So we've brought her into the operation theatre. So what is your role now? Obviously you need to put us to sleep, to put us under. Yep. So what happens from here? Okay,
so once we come into the operating theatre, we will attach our patient to monitoring. So this is our anaesthetic machine here. This is our organ trolley over here, which contains all our medications, our drugs, airway equipment, intravenous lines and cannulas. So pretty much everything we need to give an anaesthetic is in this trolley over here. We've got syringes here and our drugs there. The anaesthetic machine is here, so we've got screens here which allow us to monitor heart rate, oxygen saturations, ECG, awareness monitoring. So we've got a monitor here that we can put this one up to here. This puts a couple of sticky Velcro dots across our patient's forehead, and we hook this up, and that'll give us a number by reading her EEG waves, which gives us an extra confirmation that our patient is actually asleep as well, despite from all the usual things we will do. So we'll put some ECG monitoring on our patient.
And so that's to ensure that they've gone under and therefore they're not conscious.
Yeah, there's a few things few methods we use to know that a patient's asleep. And generally, if they don't jump off the bed when the scalpel hits them, then that's a good chance they're asleep.
Okay. Yeah.
So we've got ECG there now. So we've got our ECG monitoring. So we monitor Lucy's heart rate and electrical activity in her heart. Oxygen saturations are here. We can hook up a blood pressure cuff to her arm, and we can measure blood pressure at any interval we want to. We've got our awareness monitor comes up there for the forehead as well.
So what's the most critical signs that you're looking for in your client when they're under? Is there anything in particular that is a big concern?
Well, we look at the patient always. So if the patient is moving or shows signs of moving, and often they'll move before they become aware, they'll withdraw a body part. If the heart rate goes up, usually early signs, if the blood pressure goes up. So these things are early signs, and we can see a change in the level of the awareness monitor. Those things will indicate the patient's a bit live, and we can say to them to stop and deal with that, giving more pain relief, increase the depth of anaesthesia, that sort of thing. So it's experience as well, so you can get to know. We give an appropriate amount of drug, and we expect a certain response. So it's as much practice and training.
And so what you're saying is that throughout the whole operation you're actually present with the surgeon, so you're always present.
So this is me doing the operation, so I'm pretty much here for the whole operation, and taking notes, writing down all the numbers and watching the monitors, talking to the surgeons, and giving each other feedback on things as appropriate. So that's the sort of the pre-game sleep, and then we give the medications into the drip, and sometimes we use anesthetic gases as well to put people to sleep, and we maintain people asleep with the anesthetic gases, which are here volatile anesthetics. So we've got a circuit here, which is part of our anaesthetic machine. We do an oxygen mask there, and we just place that around the patient's face, and they can breathe some oxygen, and turn the oxygen on, they can breathe that. We're given some oxygen before the operation, before we put them to sleep. We'll fill up the lungs with oxygen, replace the nitrogen. That gives them a safety, a buffer to breathe some extra oxygen, and then off to sleep.
So, I mean, like 200 years ago, anyone who had surgery was considered an absolute terror. Now, it's almost pain-free, we don't even feel it. What is the major advancements that you have, and what are the drugs that you're using to really help bring that pain relief to light?
Well, the advances, there's so many. We have drugs. Which we really have drugs back then. So we're now able to give drugs which have a very specific effect and a known effect, and we know the doses to give because of clinical trials. So we give the right dose of drug, and we give drugs for pain relief, drugs which help you forget, anesthetic effect as well. The general anaesthetic drugs which put you to sleep, and anaesthetic gases which maintain anaesthesia. So all these things are relatively new advances. And monitoring is a lot more sophisticated than it used to be too. So these sort of machines, these didn't exist when I started anaesthetics 20 years ago, so it's all become electronic, computerised, very high tech, and advancing all the time. So that's great.
So one of the biggest concerns that most people have when it comes to any operation is becoming awake or feeling what's going on, and actually then unable to communicate that. So how do you ensure that a person's asleep, that they're not conscious and not feeling anything?
So with the awareness, we discussed that a bit before. If a patient is paralysed, and sometimes we paralyse patients, relax their muscles so the surgeons have much better access to surgical field, and so that we can control their breathing. So in those circumstances, if we paralyse a patient for the operation, relax their muscles, then they're not able to move, they're not able to call out if they're in pain. So in those cases, we'll be using the awareness monitor, and we're still looking at those same parameters before, so change in heart rate, change in blood pressure, those sorts of things still happen. So we've still got these other markers. But if the patient's not relaxed and hasn't muscle relaxing on board, then you'll see the patient will move a little bit, so that gives you another early sign.
Okay. And so in terms of all the monitoring, that's what you're really doing essentially, is making sure that they're asleep and that they're happy throughout the whole process. If a crisis happens, what are some of the things that you actually have to do to actually intervene and help them in the situation? So
in the theatre complex, it's all teamwork. So we've got a large team of professionals. So we've got a surgeon and their assistant. We've got my anaesthetic nurse, and there's other people all around the theatre as well. So scouts and get equipment for us. So in a crisis, we call for help, and lots of people will come and usually help out, and it makes sense because we're all trained to do that. But it comes down to ABC, so we look after the airway and support the airway, breathing, circulation.
And is there a particular role that you play in that? Like, is there different drugs that you give, or?
Well, communication with the surgeon. So I'll tell the surgeon there's something bad happening, and if he can stop surgery, and they can sometimes help out as well. They can obviously give us feedback, and I can say what's happening and what we need to do. So we give drugs. So if there's no arrhythmia, then we can give drugs to try and settle down and stop the arrhythmia. If there's loss of blood, then we can call for blood products to be given. So there's each separate crisis has its own response, and we've got everything in theatre to deal with those things. So this is the place for it to happen.
And you were saying you have an airways monitor or machine?
Well, we put an airway. We will normally, so we don't put a patient to sleep. We normally will secure an airway first. So there's a few devices we've got here. So we've got a little ring spasm there. So we've got airway. We've split an airway open with this one, so a Gadell airway. And we've got soft breathing tubes here, which will go in the patient's mouth and sit above the vocal cords and allow them to breathe themselves through the anaesthetic gases through this as well. And then if we're going to put someone to sleep and give them muscle relaxant, then we'll put a tube into their ring through the vocal cords, isolate their airway, so we protect their airway from any stomach contents coming up. And through this tube, we can attach it to the anaesthetic machine, deliver oxygen, deliver anaesthetic gases, and breathe for the patient to support their breathing while they're asleep. And to put the tube in, we've got this is a laryngoscope, which is a torch at the end, and that allows us to pop. So pop your chin back for me. So put that down the side of the tongue and reflect the tongue inside, and we can see the vocal cords, and we can pop the tube through the vocal cords.
Yeah, wow.
And the recent advancement we've got these days, a video laryngoscope. So we now have a device here which has, I can show that through camera there. So it's a small video screen there, and we do the same technique. So we put it down in the mouth, put the tongue inside, and we can see more around the corner. So this machine, this laryngoscope actually helps see.
Wow.
Can turn a difficult airway into a much easier airway. So these have been fantastic, real game changing for us. Another thing is to help make the anaesthetic experience safer.
That's wonderful. That's wonderful. Okay, so then the operation is over. What is your role now? Do you still play a role? Because I mean, you knocked them out, they've got through, and it was all successful.
So at the end of the operation, the surgeons have finished their work, and then it's time for us to assume the patient is stable, wake the patient up, and get them out of recovery. So we'll turn off the anaesthetic gases, turn off the anaesthetic infusions that are keeping them asleep. We'll make sure they've got enough pain relief on board that we think they'll need, and then they'll emerge from anaesthesia, so they'll wake up, and we'll normally take the airway out. That's one of these electric field tubes there, and we'll take it out before they go to recovery, and just get them breathing spontaneously on some oxygen, make sure they're stable, the airway's stable, their circulation's steady, and then out to recovery to get them done by the recovery nurses. And
is that where your job finishes, or is there still follow-up following that?
No, so I'll still supervise the patient's progress in recovery.
Yep.
The anaesthetic nurses, the recovery nurses will call me if there's any problems. I'll have some guidelines for pain relief and intravenous fluids, and they'll keep a close eye on the patient while they're waking up, make sure they're stable, and if they've got any concerns, they'll call me in theatre, and I can troubleshoot that. And then once they're stable, they go up to the ward and continue their recovery there.
Wonderful. Wow. So one of the myths that we were talking about earlier was the fact that most people don't even think that you're a doctor. And I mean, you have an incredible role to play in actually any operation, really, don't you?
Yeah, it's all teamwork. You can't do an operation without a surgeon or an anaesthetist, really, and without the whole the nursing staff and all the crew. So everyone plays a vital role, and it's all about keeping the patient safe and getting them through an operation safely.
Well, look, thank you so much, Dr. Phillips, for
pleasure.
Giving your time and allowing us to come in here and check out everything that you do. And thank you everyone for joining us. And Lucy, thank you for helping us out. You've been a great patient. I was very impressed. And look, thank you everyone for joining us. I'm sure you found it extremely interesting. If you want to join us again next week, we're going to have another amazing interview for you. 12:30, same time, same place. Remember, healing is a gift, health a responsibility. See you next week.